Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the Deep Dive, presented specifically by the Surgical Edge podcast. Now, this content is tailor-made for you, the surgeons and doctors navigating the rigorous world of surgical training. Before we begin, just a critical word. This content is for reference only. Always follow your local guidelines in clinical practice. Okay, let's unpack this then. Securing a top ST3 General Surgery training number in the UK. It's famously described as a marathon, right? But it really culminates in that final sprint, the high-stakes interview day. So we're diving into a comprehensive guide for success today, and we're focusing not just on what knowledge you need, but crucially how you organize and present yourself to really earn one of those top ranks.
Yeah, that's exactly it. The challenge for candidates often isn't about a lack of ability. It's more about a lack of structure, The interview assesses candidates against the National Person Specification, and it does that across 4 critical domains. Our mission today really is to give you the blueprint, the structured preparation phases, and the exact frameworks you need to turn your professional achievements into a winning narrative.
And those 4 pillars that define success. Let's quickly list them. They are clinical skills and knowledge. Academic and research, management and governance, and finally, communication and professionalism.
Spot on. They really cover everything you need to show you'll be a safe, effective, and collegiate registrar.
Okay, here's where it gets really interesting for me. Success doesn't just happen on interview day. It starts months before. So if we frame this whole process as a journey, what's the fundamental structure we need to map out first?
Right. The prep has to begin with absolute clarity on the goalposts. You need to know what they're looking for. The interview itself is typically structured into 4 stations, and they mirror those 4 competency domains we just mentioned. What candidates sometimes forget, I think, is that they're not just being judged on what they did, but whether their experiences align perfectly with that person's specification.
Okay, so if the person specification is the target, the bullseye, what's the first actionable step? Like right now, what should someone do?
The primary, absolutely non-negotiable starting action. Download the latest person specification and handbook. Seriously, think of it as your study guide, your Bible for this process. Every single answer you practice, every piece of evidence you gather, it should explicitly link back to a requirement in that document. Honestly, if you can't link your achievement to a bullet point on the spec, it's basically dead weight for the interview.
Let's jump into phase 1 then. Building the evidence, and specifically the portfolio station. This sounds like your big chance to shine. But it's not just listing achievements, is it? It's about curating that powerful professional narrative. How do we structure that evidence effectively for, maximum scoring?
Yeah, it requires a really systematic review and, crucially, deep reflection. You absolutely must create a master document, list all your audits, your QIPs, publications, courses, everything. But the real difference, the thing that separates a high-scoring candidate from a middling one, is how they present that evidence. You need a rigorous, structured summary for each item.
Okay, we've heard there are 4 mandatory components to that summary. Let's break those down. What are they, and how do we add that quality insight?
Right, so for each entry, you need to state, 1, what the project actually was, simple enough. 2, what was your specific role, and use strong active verbs here. Don't just say involved in. Say things like, I designed the data collection pro forma, or I led the presentation to the department. 3, the measurable outcome or impact. This is so crucial. A low-scoring candidate might say, I was involved in an audit and it improved compliance. But a top-scoring candidate, they'll say something like, I designed the pro forma for the 2nd audit cycle, which directly improved WHO surgical safety checklist timeout compliance from 60% to 95% across both elective and emergency lists. See the difference?
Oh, yeah. That quantifiable impact completely changes the tone, doesn't it? Makes it real.
Absolutely. And then number 4, the reflection. This is where your maturity really shows. Instead of just saying, I learned a lot about teamwork, a high-scoring reflection uses structured tools like the STAR technique or maybe PDSA for QIPs to show actual growth. So, for example, I learned my initial communication with the nursing team during the QIP rollout was perhaps ineffective. That's situation task, which caused some delays. So I subsequently implemented SBAR for handovers, that's the action, ensuring crucial information about the compliance data was standardized. And that led to the measurable 95% rate. That's the result.
That focus on specific learned behavior rather than just generic feelings, that's the kind of intellectual maturity they must be looking for.
It really is. And you need to be able to use that STAR technique: situation, task, action, result almost instinctively when you're discussing leadership, teamwork, or even handling mistakes. And for quality improvement projects, just remember the gold standard is completing 2 full cycles. It shows you can actually implement change and sustain it, not just collect some data once.
Okay, let's transition now. Phase 2, the pressure cooker. Starting with those clinical scenarios, they aren't just testing your knowledge dump, right? They're testing the process of your thought under stress. What's the guaranteed safe structure for managing those acute, high-stakes cases?
The structure is absolutely paramount, and it starts the same way every single time. Patient safety first. You must always begin with a structured A, B, C, D, E assessment, and state explicitly that resuscitation and assessment are happening simultaneously. Don't just assume they know.
Right. Everyone knows A, B, C, D, E in theory.
Yeah.
But where do candidates tend to fall down when they're applying it in that high-stress scenario? Where do we fail to think beyond the textbook steps?
Well, a common failure is jumping the gun. They hear sudden abdominal pain, maybe, and immediately launch into diagnosing a perforation, skipping A, B, and C. But the interviewers are testing whether you are a safe doctor first. You have to buy time, keep the patient alive by addressing life threats systematically before you rush to confirm the specific surgical diagnosis.
That's a fantastic insight. Slow down to go fast, essentially. So beyond the AE structure, what are the key structured approaches we absolutely must have rehearsed for those, say, top 10 acute presentations?
You definitely need rehearsed structured plans. Think about cases like necrotizing soft tissue infection, acute limb ischemia, upper GI bleeds, variceal versus non-variceal. I'd also include things like an unstable obstructed hernia, where you need to talk about bowel viability concerns, or spotting the subtle signs of acute mesenteric ischemia. Your plan for each needs to cover diagnosis, immediate management, investigations, crucially, consultation, getting senior help, and then definitive care options.
When the decision gets complex, say the classic choice between a Hartmann's procedure versus a primary anastomosis in emergency colorectal surgery, how should a candidate demonstrate competence there?
They want to hear about shared decision-making, even in an emergency context where possible. You need to discuss the complexity of that choice simply. Explain the risks, the benefits, the alternatives clearly, perhaps to the family if the patient can't consent, and you must demonstrate the maturity to realize these big decisions are rarely made in isolation. Saying you'd seek senior advice isn't weakness. It's an essential part of being a safe, effective registrar.
Okay, so once the interviewers are happy you're clinically safe, they often pivot, don't they? They start testing your intellectual curiosity, your analytical skills. Which brings us neatly to the academic station. It sounds like it demands much more than just listing a publication you were vaguely involved in. What's the level of mastery required here?
It's about critical appraisal mastery. And that applies just as much to your own work as to any paper they might give you. You've got to know every project you list inside out. The rationale behind it, the methodology you use, the statistical tests, why those tests, the limitations, ethical approvals, and importantly, its actual contribution to the field.
Okay, scenario. What if the interviewers directly ask you about a clear limitation or a weakness in your own published paper? That feels like high pressure.
Yeah, it can be. But the top candidate doesn't get defensive or try to deny the weakness. They demonstrate forward thinking. Instead of getting flustered, you immediately pivot to mitigation or future improvement. You might say, yes, you're right. A clear limitation was the retrospective design, or maybe the small sample size. Then you add, if I were designing this study now or for follow-up, I would address that by designing X prospective study or collaborating with Y Center to increase numbers. It shows you understand the scientific process and you can think beyond the existing data.
That's smart. And they might also just hand you an abstract or short paper you've never seen before and ask you to appraise it right.
Yeah.
We need a framework for that, too.
Definitely. You need to practice using the standard critical appraisal structure under pressure. Start with the introduction: was the research question important and relevant? Then move to the methods: was the study design appropriate? What about potential biases? Blinding. Then analyze the results. Do you actually understand the statistical output? Things like p-values, confidence intervals, maybe number needed to treat, or NNT. And finally, the discussion and conclusion. Do the conclusions logically follow from the results? What are the implications for practice?
NNT, number needed to treat. That often trips people up, doesn't it? What's the quickest way to show you understand its importance when you're discussing results on the spot?
Yeah, focus on conveying the clinical relevance, not just the number. Instead of just stating the NNT was 50, explain what that actually means in practical terms. You could say, well, although the p-value suggested statistical significance, the NNT of 50 indicates we would need to treat 50 patients with this new intervention to prevent just one adverse outcome. And that raises questions about its cost effectiveness and perhaps its broad clinical application. That shows you can translate the statistics into real-world bedside practice. And one more thing on academics. Be current. Know about major recent trials impacting general surgery. Think about NIHR trials on mesh use or the evolving debate around antibiotics versus surgery for certain types of appendicitis. Show you're engaged with current evidence.
Right. Okay, moving on now to phase 3, demonstrating professional maturity. This is about management and governance. This tests your capability not just as a surgeon, but as a functioning NHS doctor who understands the wider system you're working in. What essential knowledge is needed here?
You absolutely have to know the current NHS landscape and the key initiatives aimed at promoting safety and efficiency. We're talking about things like PSRF, GERT, NELA, maybe ERS pathways, depending on your interests. And these shouldn't just be acronyms you can list off. You need to understand why they matter.
Okay, let's slow down there for a second. PSRF, the Patient Safety Incident Response Framework. Why should an ST3 candidate really care about that?
Well, PSIRF is important because it shows you understand that NHS is actively moving away from a blame culture towards systemic learning. So if you're discussing an adverse event in the interview, you need to frame your reflection in terms of learning from the incident systemically, not just finding individual fault. Similarly, GIRFT, getting it right first time, that isn't just another audit. It's a huge national push for standardization to reduce unwarranted variation in practice and outcomes across different hospitals. You should ideally know how GIRFT recommendations might be affecting your specialty specifically.
Okay, and when faced with those tricky ethical dilemmas or maybe patient safety incidents during the interview scenarios, structure is key again, I assume.
Absolutely. For ethical dilemmas, let's say, negotiating consent for a confused patient who lacks capacity, use a systematic approach. Identify the core conflict, maybe autonomy versus beneficence. Name the stakeholders involved. Cite relevant law, like the Mental Capacity Act. Mention involving the MDT, and always state you'd seek senior advice. And crucially, if there's a patient safety incident scenario, always demonstrate openness and honesty. Your framework should be something like, first, apologize, not necessarily admitting guilt, but showing empathy. Then, ensure immediate patient safety. Inform your senior immediately. Complete a DOTX or your local incident report. And then, critically, reflect on how systems might have failed, not just focusing on individuals.
And finally, the scenario that really tests true maturity. Dealing with concerns about a colleague's poor performance or perhaps their conduct. How do you navigate that minefield?
Yeah, that's a tough one. Always start by centering the discussion on patient safety. That's your primary concern. Avoid being judgmental or accusatory. The sources, and frankly good practice, suggest the first step is usually an informal, supportive chat with the colleague directly. Try to understand their perspective, see if there's an underlying issue. You only escalate perhaps to a clinical or educational supervisor or their consultant if that informal approach doesn't resolve the issue, or, of course, if the risk of patients is immediate and substantial. The goal should always be resolution and safety, not confrontation.
Okay, so we've covered a massive amount, the content, the evidence, the frameworks. What does this all mean for those final days and weeks leading up to the interview itself? How do we pull it all together to maximize performance and really nail that top rank?
Right, the final push. Mock interviews are absolutely non-negotiable. This is where you pressure test all those frameworks we've discussed. Practice with registrars, practice with consultants, and importantly, record yourself if you can. Get specific feedback not just on your answers, but on your pace, your body language, how you handle interruptions, and whether you maintain structure when you're under pressure.
That practice really ensures, your CV, your portfolio, almost blindfolded, right?
Exactly. You shouldn't be fumbling for details about your own projects. And adopt the right mindset. Remember, you're not a medical student anymore. You're presenting yourself as a potential colleague, applying for a registrar training number. Be confident, stay calm, be collegiate.
I think that simple technique you mentioned earlier, just pausing before every answer, sounds incredibly powerful, but easy to forget in the moment.
It is. It gives you those vital few seconds to structure your thoughts. For pretty much every question, just take a deliberate pause, 2, maybe 3 seconds. Breathe. Quickly structure your answer using the appropriate framework STAR, AE, the ethical one, whatever fits, and then start directly. Maybe acknowledge the question first, like, thank you, that's an important ethical question. I would approach this by first identifying the core conflict. It sounds much more composed.
Okay, final question on this. In your experience, looking at the candidates who really excel, what genuinely separates that top 10% from the rest of the, let's face it, already highly qualified pool?
I think it boils down to maybe three things. First, those insightful reflections we talked about, moving beyond the superficial "I learned a lot" to specific examples of changed behavior or understanding. Second, a clear awareness of their own limitations. It's the maturity to confidently state something like, this is actually quite a complex situation, potentially beyond my current competence as an ESHGA core trainee. My immediate safe action would be to escalate this and seek the advice of my registrar or consultant. That confidence in knowing when to ask for help demonstrates supreme safety.
Which, ironically, is exactly what they're testing for.
Precisely. And the third factor, I think, is that genuine, visible enthusiasm. Enthusiasm for the specialty, for surgery, for patient care, it has to shine through in every answer, even the ones about governance or audits. They need to believe you really want to be a general surgeon, and for the right reasons. So to sum up, achieving that top rank in the ST3 process really requires combining comprehensive clinical knowledge with that professional maturity. It's about presenting yourself as a safe, reflective, and proactive future colleague. By mastering these structured frameworks we've discussed, you essentially ensure that every achievement you list, every answer you give, translates into maximum points on the day.
Preparing for the ST3 interview is, without doubt, a massive undertaking, almost a full-time commitment in itself. We've aimed to cover the necessary tools and structured approaches today to really maximize your chances of excelling. So consider this as your final provocative thought to take away. We discussed quite a few frameworks: STAR, SBR, the AE assessment, PDSA, the ethical structure. Thinking about your own preparation, which one of these frameworks do you think offers the biggest immediate return on investment for improving your potential interview performance? And how will you consciously integrate practicing that specific framework into your routine this week so it becomes absolutely second nature when you're under pressure?
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.